I've just flicked back to this table here. You can actually see that we had sort of up around 80% success rates in the younger age groups, but about 70% success rate over 70 years of age. I actually treated actually a little old lady who we use in Australia sometimes as our model patient. She's 94 years of age, and she's had a dramatic success. So even the older people. We have had something which I've named the Schwinn technique, which is we've had one older lady where we've used her daughter's blood. She had, not so much because of her age, but also she had a lot of medications and medical complications. And of course it was a matter of checking cross-matching, checking for serologies were negative, and she had a good result. Yeah. But that's a rare thing that we've used, that Schwinn technique.
That's what.
For this case that we did cross-match, and it was the daughter. I actually believe that by removing the red blood cells and injecting intraarticularly only a small volume, there probably aren't that many cross-match issues. But we cross-matched anyway, just to be on the safe side, and there were compatible groups. But yeah, that's an option for a very elderly patient. It goes into a very interesting area. Right at the start of one of those educational videos you saw, there really is something, I believe, within our languages and within our cultures, often truths are revealed. And there's been a fascinating thing over the centuries of the myths evolving blood as a healing thing, right back to vampire myths and using the blood of young virgins and things like that as somehow or other having healing things. And now really the science has caught up with it, and the latest studies are quite amazing. They've taken mice and taken young mice, removed their blood, injecting it into old mice, and the old mice start acting young, and you take old mice, take their blood, inject it into young mice, and they start acting old. So there's, in fact, a lot of communication, a lot of messengers within the blood about healing and about regeneration. And we've come onto that, but in fact, it's been within our culture that there might be these sort of healing things for centuries. Well, yeah. Well, our data shows there's a reduced healing rate, but 70% is still a pretty good success rate. It's a good question. In fact, what we need to do is to further break that down into over 80 and over 90 age groups. But we've only had a few patients over 90, and in fact, they've done quite well. So there's no doubt you get less benefit as you get older, but it's still worthwhile. And also, one of the things that we look at is who are the real people who are going to benefit from this regenerative medicine. And clearly, people under 50 years of age who are looking at total joint replacements or even arthroscopic surgery. I'm not sure if you're up with the latest data, but it really shows that the old arthroscopic cleanup of a knee, they've done placebo-controlled studies in Canada, and we actually did sham arthroscopes, and it showed no benefit after 2 years of the arthroscope group versus placebo group. So for a lot of these younger people who are looking at treatment, they're actually too young for total knees and they don't benefit from the arthroscopic cleanups. And so we have a lot to offer that group. Then you've got a middle group, and the particular reason you don't want that, of course, is that people under the age of, say, 50 having total knees, the total knee is not likely to last them their lifetime. And so joint replacement surgery in that age group is a real problem. Because, as you probably know, revision surgery on replacement is horrendous and very rarely done, and the complication rate's enormous. Then you've got a group for whom surgery is a valid option, which is the groups maybe in the late 60s, early 70s, where their joint replacement will probably last them for life. And then you've got a group that we see a lot of who are late 70s going into 80s. And although our success rate is slightly lower, their options are vastly diminished because, as you probably know, most surgeons won't do a total joint replacement in someone over the age of 80 because the anaesthetic risks are too high. And many of you will know that people over the age of 80, they often don't wake up with all their marbles, even if they've survived the operation. The recovery time and the memory loss and cognitive diminution after major surgery is quite significant. So in that 80+ age group, we have a lot to offer those patients because they have no other options. And I think that, it's very satisfying work that we're doing in that area. A lot of people, we're really making their lives, particularly a 94-year-old lady. She's actually the mother of a friend of mine, and she'd become completely housebound as a result of her knee pain. She couldn't leave the house. She was miserably depressed. In fact, she's a delightful lady. One of her sources of sadness was she'd had to stop work. And I caught up with her about 10 days ago. And not only is she now happy and she's able to get on with life, she's actually back at work. and that means a lot to her. So it really is, she's gone from being depressed to living a full and active life. And that's a wonderful gift for us to be able to share with people. Contraindications are usually elicited through history of the patient, particularly the medications they're on. And the only really absolute contraindications are hemopoietic malignancies. We treat differently sometimes people on warfarin, particularly there would be a contraindication for stem cells. It's not a contraindication for PRP treatment. And we're very cautious about people who are suffering from rheumatoid arthritis. We really want, you've got to make sure you're clear what the diagnosis is. And so if the diagnosis is other than osteoarthritis, so we can and have injected into septic joints. We had an orthopedic surgeon who actually wanted us, it's a total knee replacement bilateral with infections in both sides. So we did inject in there, and it did give the patient significant pain relief, but clearly it's not a cure. It's just a buying time to horrendous surgery in that situation. But we'd have to be aware of the infection before we went in, and which we were. But it's a relative contraindication is infection. In regards to protocols, I think the strength of our protocol is that we have the largest database. And it's almost fortuitous. In the early days, 4.5 years ago, I spent a lot of time talking and thinking about the different methods. Now, I chose the method that we use based on 2 or 3 things. It's actually one of the simpler methods. It's quicker, and it involves less risk. So as you process, the more you process, you actually increase the chances of a contamination for an operator area. So that's why I chose this method, and we've actually stuck with the same method for 4.5 years. So we have a massive amount of data on this method. Now the irony is that if you follow the politics of this, a lot of people became excited because it's called platelet-rich plasma, and so they've done some really, what I call bizarre things to try and get the maximum levels of platelets into their mix. Now, fortunately, we never went down those paths, so we never tried all these other things. And now, a lot of the data is showing that it's not only are the higher levels of platelets not getting you better results, they're actually proving you're getting worse results. And the reason is, as I think most of us now realise, but almost no one realised 4.5 years ago, it's not the platelets that are actually the key ingredient. It's the growth factors, maybe the exosomes. So when we use our method, we're actually getting a very large number of growth factors and exosomes, but not an extraordinary level of platelets. And that's, I think, our strength, that we have the data, that we have the simplicity, and we have the safety. We haven't talked a lot about the light activation, but again, that's one of the fortunate things. Almost from day one, we've light activated all our PRPs. And I think when we look at our data, which is very large, against all the published databases, No one has better results than us. A lot of places have similar results. No one has better. And most very strongly control who they accept in. But we don't. Our data includes some cases that we call compassionate, where I've actually advised the patient, your chances of success are very small, but you have no other treatment options, so we'll treat you. The severe grade 4s, all the severe grade 4s are in that data. That 22% failure rate includes the worst case patients. So, and a lot of studies won't include that data. So I think we've been very fortunate that we were using the light from the very start of our data collections.